Welcome to Buffalo HealthCast, the official podcast of the University of Buffalo School of Public Health and Health Professions. We're your co-hosts, Skylar Lawson
and Tia Palermo.
In this podcast, we cover topics related to health equity in Buffalo, around the U.S., and globally.
This season, we'll be talking about nutrition from a health equity perspective. You'll hear from community members, practitioners, researchers, students, and faculty on topics related to nutrition, including food security, food access, social protection to improve nutrition outcomes, food apartheid, culturally tailored nutrition interventions, and more in this season of Buffalo HealthCast.
Everyone, and welcome to another episode of the Buffalo HealthCast, the University at Buffalo's premier health podcast. I am your host today, Nicole Klem, a registered dietitian and director of the Clinical Nutrition Graduate Program in the school. And with us today is Catherine Brown, a registered dietitian and owner of Inclusive Nutrition Counseling, a nutrition counseling practice. Her model focuses on individuals with mental health issues and disabilities. She's working on weight bias in healthcare and is focused on a health at every size approach to help clients make and achieve small goals toward overall health success. Thank you so much for taking the time to speak with us today. So I'll begin by asking you to tell me about yourself and tell me about your practice model and how it's unique.
Thank you for having me. Like you said, my practice is focused a lot on mental health and on treating people with disabilities. My goal is to create somewhere where people could feel safe who typically don't feel safe in normal healthcare settings. They feel like doctors don't listen to them or just blame either their mental health or their weight for whatever medical issue they're having, and don't really have the patience to help them work through changes that they need to make to improve their health and quality of life. I like to focus a lot on obviously small changes like you said, but also really focusing on the patient and how their life is and how we can find changes that will work for them. Because, overhauling their whole diet or making a bunch of changes isn't always very realistic for someone that's already struggling with a lot of things. But that also doesn't mean that there's nothing we can't do to make their situation better and make them healthier.
And what drew you to this type of practice?
So I am a patient myself, and I've spent a really long amount of time at doctors' offices, meeting with doctors, and one of my doctors, this was probably 5 or 6 years ago, I came in with a variety of complaints, and she told me that it was psychosomatic and that there was nothing wrong with me and I would never get better. And it was really difficult for me, and I actually avoided doctors for 2 years after that. And then I finally got diagnosed with lupus, so it was not psychosomatic. And I definitely know a lot of other people out there experience similar things and really want somewhere where they feel safe and they feel heard and they can get the help that they need. And so that's kind of where I wanted to create something, because I wanted to be a space where people weren't afraid to come see the doctor or the dietitian, and they felt like they could be open about their challenges and not be judged. And I think that's really the start to really changing overall. Because, if they're not going to be open with their provider because they're too afraid of being judged, then you can't really help them.
Yeah, all right, interesting. Definitely a little area of dietetics that is important in different populations. How does your practice work to minimize weight stigma specifically in nutrition counseling?
Obviously, I'm just going to go over what weight stigma is, but it's basically this bias towards the fact that weight is, the root cause of a lot of issues and that it's what needs to be addressed. And a lot of doctors, when you come in for like knee pain, back pain, even depression, they'll be like, well, have you tried losing weight? And for a lot of patients, one thing is weight loss is not really achievable. And we want it to be like calories in, calories out. Oh, you're just going to reduce what you eat and you're going to lose weight. But for a lot of people, it's really, really difficult. And the second thing is that some people have lost weight, like maybe they were 300 pounds, now they're 200 pounds. And the doctor's like, well, you just need to lose weight. It's like, I lost 100 pounds, which was really difficult. Expecting them to lose more is not really realistic. And the truth is that there's no condition that only obese people get. Every condition that obese people get, skinny people get too. And so we have to realize that while it might be a contributing factor, usually there's still other stuff going on and there's usually other treatments. And that's one thing for me is, I was really pushed to lose weight to get better. But as I met more people, there's a lot of people with autoimmune diseases who are very thin and they still have joint pain and they still have all of the symptoms I have. And so realizing that like maybe it's not weight, and then being able to make changes and feeling better even without weight loss. So sometimes, we think like, well, if you're eating healthier, you must be losing weight, but that's not necessarily the case. You can eat healthier and be maintaining weight and feeling better and having better cholesterol and better blood pressure and all of those things.
And in the counseling settings, what tools are you using to, make the patient either feel more comfortable with their experiences of the past in healthcare or combat some of the stigma they might be coming to you with?
So I would say my patients actually talk the majority of the sessions, especially for the initial one, and we really go through a lot of different things, like what diets have they had done before, how do they feel about certain things, how do they feel about their weight, what has their doctor told them, what are their goals, because some people are still kind of interested in losing weight, and they're like, hey, if I lose a little bit of weight, great, but I don't want to lose a ton of weight. I don't think that's realistic, which is awesome. There are other people that are like, I don't want to lose weight, I don't think it's realistic, and I have a history of eating disorders, so it could be dangerous for me. I think actually the first thing that's helpful is that I am also overweight. There's a lot of people in the like weight inclusive space who are very thin. It's like actually a trope of like really thin dietitians who are like, weight inclusivity, it's great. And it's awesome to have lots of different people championing it, but they don't really understand what it's like. So I think that's really helpful. And then just really listening to them, listening to their history, what their concerns are. We actually talk a lot about educating. So, they'll think, well, I have to, lose weight in order to improve my cholesterol. That's what my doctor said. And we actually talk about what is the science behind that? What do you actually need to do to be healthy? And it kind of makes them feel better that they don't necessarily have to lose weight to improve their health.
And so folks don't, maybe haven't always felt heard, and part of your goal really is just to listen to some of their story.
Yeah, and validate their feelings, because a lot of them feel like this is really hard, why can't I be successful? And then as I talk with them, explaining you're not the only one that's not successful. 99% of diets fail. Most people regain the weight. And so it's not unusual that you have those struggles, but also that doesn't mean you should give up and that there's nothing you can do.
Sure. I'd be curious to learn a little bit more about the accessibility of nutrition counseling in general. So again, people might be uncomfortable in the healthcare system, but still know that they're, seeking some nutrition changes. Is it something that is affordable, that all groups have access to, or are we seeing some gaps in who can receive nutrition counseling and who has access to it, or, understands how to seek out someone like you? So here you are providing like an excellent service for people who may have been, feel like they've been harmed by the healthcare system or the stigma or bias out there, but how do they get to you, or what gaps are in sort of access to nutrition counseling?
There's a lot. This could, be a long discussion. I would say one thing is that doctors and patients don't always know we exist and what we can do. And so people don't realize like we can help with mental health and we can help with a variety of different conditions. And they kind of think, oh, well, you just do diabetes and heart disease and I don't have those, so I don't need to see you. So I'd say the first thing is having people realize that nutrition can affect a lot of conditions, actually the majority of them. The second part to that is there's a lot of issues with insurance coverage. So some insurances are great. They cover so much nutrition counseling. And actually most commercial insurances cover a huge amount of nutrition counseling. It has no copay because it's under preventative. Usually there's no cap to the number of times they can see you. So like if they need to see you every week, they can see you every week. The issue is Medicare only covers diabetes and kidney disease, and they will cap you at 2 to 3 hours per year. So basically, if you have any other issues and you're on Medicare, we can't help you. And this is really hard because there's people who, when they go on disability, they end up on Medicare, Medicaid if they're permanently disabled. And Medicaid does not cover any nutrition counseling. And Medicare obviously only covers those two. So if people are, let's say they're underweight, they're actually malnourished. You know, I've had patients where they can't absorb nutrients properly. She was becoming severely malnourished because she couldn't absorb nutrients properly. She's like, I'm worried that I'm going to die if I don't fix this, but she's on Medicaid and it's not covered. And so then you get stuck with like, do you take these patients pro bono because they don't have money to pay you, or do you, send them away? And this definitely becomes really challenging and very hard because you want to be able to help everyone, but also you can't have like an all pro bono company. So I know a lot of dietitians who will have like several pro bono spots in their schedule. So they'll say like, okay, I'm currently going to work with 2 pro bono patients. And then when those ones leave, they then will see another one. But obviously it's not a large majority of your practice. There's currently a bill to expand Medicare coverage for MNT. And then in Medicaid for New York State, they've expanded it to pregnant women and infants, I believe. So we are getting there, and it's likely that the Medicare bill will pass, and hopefully it does, because then it will expand to so many more areas. It probably will still have the 2-hour limit, which I think is not enough for a lot of conditions and a lot of people, but at least they will be able to get something, because right now they can't get anything.
And how about the delivery of services? Do you do a lot of telehealth? Are you more virtual? Do you see people more in person? One of the barriers I think is time and transportation and, scheduling an appointment that might be in a different location than they're used to going.
What's really interesting is that for some people, in person is more accessible. Mm-hmm. They feel like they struggle with technology, especially older people. Or they have hearing problems, they can't hear as well, all of those things, so they like in person. And then other people prefer telehealth because it's much easier for them based on their needs. I have a patient with 6 spinal fusions, and she has to spend a lot of time laying down, and so I'm able to see her. She uses her phone, and I actually see her from her bed, and we're able to, talk and provide the care that she needs. I also see patients in other states, so I'm very niche in what I do. And I will have patients who, maybe they have diabetes, but they also have a history of eating disorders, and they need to treat their diabetes in a way that isn't going to trigger their eating disorder or their mental health. And so then they'll come see me. And I actually love it. I have a lot of patients in Washington and California. And it's awesome to be able to have really good provider-client fits because of that.
I think of folks, in rural areas that might not have a private practice dietitian, within 15, 20 minutes, the way we might have in Western New York. I'm sure, Washington and Oregon, could be fairly rural areas. And how do we provide services to those folks as well? And so you had mentioned your patient with some of the spinal fusions. Do folks with disabilities experience more food insecurity? And are they maybe more underserved by the healthcare system or by dietitians?
Couple of things. So actually going back to that patient for a second, she is on Medicare, which isn't covered as we talked about. And so luckily, she actually lives with her parents at home because of her disability, and her parents are able to pay for her to get nutrition counseling. But if it wasn't for that, she wouldn't be able to access it. And because of those support systems, she is able to, get food. Her parents help her make food, all of those things. But there are other patients who are actually pro bono who are on Medicaid where they just get food stamps. And then in addition to food stamps, I think they get $1,000 a month. And, they live in a really expensive area. They live in the Portland area. And so most of their money goes to rent. They don't have extra money to go towards food, so they have to live on food stamps. And the amount food stamps give you is very low. And what's actually interesting is there was just this kind of viral thing going on about the thrifty food plan. Have you heard of it? Mm-hmm. Yeah, so the USDA has this plan, and they're like, this is what, cost-conscious people should eat that is affordable. And so food stamps are based on this. So basically they take food stamps and they're like, oh, well, you can buy these foods, you're fine, you have enough money. But it is totally unrealistic. It's like, you can't have tea, you can't have a coffee. The majority of your food is fruit intake. You have to consume a lot of fruits. It's nothing pre-made. You're allowed to have one pre-made frozen meal per month. And the thing is, people who are disabled, it's not easy to get on disability. So you are really disabled. They are not able to cook. and everything is like kind of raw form, unprocessed. You need to put it together, you need to make it, and that's just not feasible for people. And so they usually end up running out of food stamps. And I've had patients where they've literally had to go days without eating because they were out of food stamps. So it's definitely really difficult. And yes, there are community resources, but there's just not enough to cover the amount of people that need more food.
Wow. And so food security really, though, is beyond the individual. This is a systemic issue that we see nationwide. And it impacts, more people than I think the average person realizes. So I think, nutrition education can play a role in this systemic food security issue. How do you think we can make nutrition education more accessible to people, who are challenged by food security issues like the one you described?
So there are some grants that will pay for like clinics for dietitians to work in, and then they'll see patients who maybe don't have insurance or their insurance doesn't cover it. And that's something that definitely, we're trying to open more of them, trying to get more of that access out to people. Definitely just more government coverage would be great. More coverage, through Medicare, Medicaid, but even like all the people that are uninsured, how do they get nutrition coverage?
Right.
And they do have some free community programs that people can go to. There's some online stuff like through the USDA, but it's not really personalized and individualized. And I found that individualized care is really what makes big changes, but that takes a lot of time and resources. So I'm not really sure how we can fix it without just, giving everyone universal health care, which would be great for a lot of people. But it is something we definitely need to work on. And at least, even if someone's low income, they meet with a dietitian, like we can help them with affordable ways to get food or meal prep or different things, for like if they do struggle with being able to purchase food and make food, we can help them with those things and guide them. So, even if we can't fix their underlying condition or help their underlying condition, we can still help them in other ways.
And I feel like some of those canned plans from the internet or from, video may not be, as culturally inclusive as we hope. And, I think what we're seeing in populations who are challenged by chronic conditions like heart disease and diabetes, the resources are out there are not necessarily the foods that they eat or the way that they cook or familiar recipes and flavors and textures. So is there... I think it's important that we as dietitians are, trained to understand a wide variety of cultural eating and eating preferences in food so we can use the tools out there to customize that to an individual. Is there anything that the Academy of Nutrition and Dietetics or the profession of dietetics is doing to fill some of these gaps or meet some of these needs?
So a lot of people that are part of the Academy of Nutrition and Dietetics, which is basically the professional organization for dietitians, they actually end up being the majority of the board that makes up the dietary guidelines for Americans. So this is where they decide like my plate, food pyramid, all of those things. And because we are mostly white women, the board ends up being mostly white women, and it kind of misses those other cultures. So definitely a big issue is education. And, it's really interesting because I just watched this webinar and it was about how when dietetics first became a profession, Black people were not allowed to go to college and you were required to have a college degree. So there were all these people that automatically could not be dietitians. And a lot of those issues have continued. I mean, all of the, there's 2 historically Black colleges, they don't have dietetics programs anymore. So really trying to figure out how we can get more diverse people into the field, and yet college tuition is rising and cost of living is rising. So it's really hard for people to go to college. I think, the newer education models are really helping, which I know you have the future education model, but actually this is the most diverse year of students we've ever had. And if they all graduate and become dietitians, we will have the most diverse dietitians ever. So I think we're on the right path.
Nice. Yep. So you mentioned a little bit before we talked about weight bias and how society really views body size. So even in the medical community, they pathologize weight. Can you talk a little bit more about what weight bias is and how it manifests in our culture?
I would say the biggest thing is that we see overweight people as being lazy or having like low willpower. So doctors are actually less, they kind of assume that, oh, they wouldn't take their medication consistently or they won't be as compliant. And that's a really big issue because, you know, if going into an appointment, the doctor's already like, well, hey, this thing could help this patient, but it's too difficult. They would never do it anyway, so I'm not going to recommend it. Then they don't get the care they need. Other things are that doing certain tests on people who are obese or fat actually needs different tools. So like blood pressure, if you are taking it incorrectly on someone who's obese, it will come out incorrectly. And one of the things they actually think that drives increased mortality in obese people is actually medical errors, because doctors are not properly trained to treat people who are obese because they are different. And so until we have a system where we can kind of like properly care for those patients, we're always going to have these issues. You know, they also, if, you know, a doctor has two patients, one's thin, one's obese, they're more likely to spend more time with the thin one because they think, you know, they care more about their health, they're going to put more effort in. And that's not always the case. So it really leads to systemic problems. The other big thing is a lot of mental health issues, because even outside of medical practice, the stigma in general, the way society treats people who are obese, which at this point, I think a third of adults are obese and like 70% are overweight. So I feel like it's actually the norm. And yet people who are overweight feel like they're the outsiders when really they're the majority. And so they have really poor self-esteem and mental health issues and all of those things. So then they're less likely to possibly get help, or even just having, you know, depression or feeling bad about yourself impacts your health. So it just all snowballs into additional issues.
So there's an approach out there called health at every size. It's been around for a while now, but it has seen a lot of popular resurgence now in eating disorder community, nutrition community, registered dietitian community. So how would you describe principles of health at every size for someone who wants to better understand it, who maybe hasn't heard of this or only heard a little bit about it?
So health at every size is focusing on basically achieving your best health without focusing on weight loss. So there are so many different things we can do to help improve health without having weight loss. And more research is showing that a lot of times when people have improved health with weight loss, it's because they had improved healthy behaviors. So someone started exercising more, they lost weight and their blood pressure improved. So they're like, oh, it's because you lost weight, when actually it's because you exercised more. And so really kind of trying to focus on things you can do to be healthier without focusing on weight at all, like taking weight out of the equation. I do have to say that, you know, this movement has really, we have people that are very passionate about how we should never talk about weight and we should never discuss weight. And I think that there's kind of a happy medium. Like, we still want to be patient-centered. And if the patient really wants to lose weight, you know, even if it is for, you know, visual reasons, or they'll feel better about themselves. Yes, you know, we talk about the risks, the benefits, how difficult it is, stuff like that, but not really saying, no, I absolutely won't help you lose weight. It's like, okay, yes, you know, we can work on your health conditions and possibly help you lose weight at the same time, but definitely not overselling the likelihood of it. But overall, it's a really cool movement because it kind of takes that part away where a lot of conditions, people are just like, well, just lose weight. And if you take that away, you're like, okay, well, what else can we do for them? And I think it provides better care.
Are there challenges to using a health at every size approach?
Definitely. I mean, there's some like people who think that it's not evidence-based, it's not like ethical, because obesity is this huge issue and how could you not treat obesity? And you know, sometimes with patients, they're very resistant. I definitely get patients who are just like, I absolutely want to lose a bunch of weight and I want to lose it really fast. And I'll tell them, I'm like, I'm not the right person for you, because that's not what I focus on or what I feel good about. A lot of people who lose weight regain it, and regaining the weight is more dangerous than just maintaining. So if someone's 200 pounds and they maintain 200 pounds, if we can get them to like exercise or eat healthier, even if they maintain 200 pounds, their health will improve. If they lose, let's say 20 pounds and then regain 20 pounds, their health is going to be worse. And in the long run, they didn't learn any healthy behaviors, or they didn't incorporate any long-lasting healthy behaviors. So I really think it's not good for the long-term health of people to focus specifically on weight loss. I mean, I do think if you do it right, it can have a place, but.
And is it challenging when you have patients that might have built environment issues to exercise, or nutrition knowledge and skill to prepare healthy meals, or to access some of these health at every size tools that aren't just focused on calorie reduction, knowing that situationally there might be other issues going on with that patient?
I would say one of the most interesting things is that exercise is not covered by health insurance, which kind of fascinates me that we're now covering nutrition and we care about nutrition, but like, why can't you see a personal trainer as like a thing that's covered by insurance? So I definitely get patients who, there are a few managed Medicare plans that will still cover nutrition, so I can see them, but they don't have the money to join a gym or have a trainer or anything like that. And they would really benefit from exercise. And especially, if they are complex, like if they have, spinal fusions, they need someone who really knows what is safe for them to do. So I'd say that is difficult. Obviously, if they have trouble driving, they don't have a car, getting to the gym is hard. And, where they live might not be good. Or let's say, okay, you say everyone can walk. Well, what if they have knee problems and they can't walk, or foot problems? Or a newer one I'm learning about is POTS, which is posterior orthostatic tachycardia syndrome, I think is what it stands for. But basically it's that, you get really low blood pressure when you stand up. And some people get it and, they stand up, it kind of equalizes, they're good. There are some people, they cannot stand up ever because like they will pass out. Or, for long periods of time. So the idea of going on a walk is absolutely out of the question. Like they have to do something that's sitting. And what is available to them, like if they had a stationary bike, they could do that, but they can't afford one. Or, how would they even get it into their house? Different things like that. So I would say there's definitely a lot of barriers. And then, obviously mental barriers. So people who have like autism, ADHD tend to have a lot of food texture problems. And so they'll have different issues with certain foods. So it's really hard to find foods that like work for them. And then especially if they're low income, it's like, okay, well, they struggle with fruits and vegetables. And, most of the ways that fruits and vegetables are the most palatable to people with these conditions is more expensive. Like having smoothies, but then you need to have a blender and you have to like buy the stuff for smoothies. So it's definitely challenging.
Yeah, it sounds like you do some troubleshooting with your patients, looking at their full picture, particularly as you're using some of those health at every size tools. Another tool in your toolbox is something called intuitive eating. Mm-hmm. And I'm curious to hear your explanation of what it is, but also what it isn't, because I think there's a lot of confusion about what intuitive eating and the role it plays in, someone's approach to, improving their health.
So the way I like to start with intuitive eating is that they've done studies on 3-year-olds and they'll give them like a juice box or whatever. And then they'll like watch what they eat throughout the day, and they will inherently just eat that many less calories. So you can like sneak calories into a 3-year-old's diet, and they will just intuitively like eat less at dinner. And so we're all built with the ability to do that. And even, you look at our grandparents, they didn't have nutrition facts labels. The nutrition facts label actually didn't exist till the 90s, and people were healthier before it, which I feel like is an interesting thing to think about. But really focusing on how you feel and how foods make you feel and how they impact you. So, in a perfect world, you eat something with sugar, you eat something fried, you like it, it tastes good, but you don't feel so good. So you decide that maybe you're gonna not eat as much of that next time. And like, that's how we're supposed to be psychologically. But then we've created this society that like messes with our psychology so much, and that also like parents and advertising and everything, that we no longer can like connect to that properly and realize that like, hey, eating this really sugary food makes me feel bad, so I'm gonna eat less of it. And then you get into like binge eating cycles and all of those other things. And so really kind of trying to go back to your roots of like, how does this food make you feel? And that's something I really do, is like not even changing their diet, but be like, when you eat foods, think about how you feel afterwards. And it's really good for people with like chronic diseases too. Like let's say they have depression. It's like, did your depression get worse? Did your joint pain get worse? Did you feel more agitated? Did you feel tired? I mean, most people still get some amount of like agitated, tired, nervous, they drink a ton of coffee. And so starting to pair that, because then if you naturally pair with like, every time I eat this food, my joints hurt more, it's not so much that you're forcing yourself not to eat it. You will naturally start eating it less because you realize it makes you not feel as good. So then you're making changes without it being like forceful and kind of, oh, you need to be disciplined. And instead it's natural and like the way we're biologically meant to be. Does that make sense?
It does. What are some things that you think people think that intuitive eating is, but it actually isn't?
I think people think it will help them lose weight. And I think people think it mostly is about fullness and like satiety, like, oh, this is how much food I should eat, or oh, I'm eating too much food. And that's true. And that has like its place in a lot of things. It has not been shown to lead to weight loss though, without doing like other changes as well. But I still think it's really, really good. And it actually ends up kind of like ballooning to other parts of your life. So if you ever do mindfulness and intuitive eating are basically really similar. You're just being mindful about your eating and your food. And so it can really help with like other aspects of life, like, hey, maybe this exercise isn't working for me, or this job, or, different things going on.
Yeah, I love that I'm starting to see some mindfulness training in elementary and middle school. And there is a little bit of, there's mindfulness curriculum, and then there's some intuitive eating when they get to food and nutrition. And so, thinking about kids controlling thoughts and emotions around food, may impact some of their practices or perceptions of food and nutrition later in life. And that, you're right, mindfulness is really something that can infuse into the stress of any other life activity beyond even just eating, for sure.
Can I add something to that?
Sure.
So I feel like sometimes actually things like nutrition labels, calorie counting, ends up undermining mindfulness because we spend so much time focusing on calories and protein and all those other things that we forget to just check in with ourselves and how we feel. Like, do you like this diet? Is it working with your body? And so that's kind of what I was saying about the nutrition facts label is like, did that have something to do with it? Like, did it just make us so disconnected from how we feel? Because now we see numbers and we're like, oh, we think we know better than our bodies, but we don't. And we really just need to listen to our bodies again.
I remember early on in practice, someone asked me, well, what's the best diet? Like, just tell me what to do, right? And this, 10 years ago, and I was like, well, the best diet's the diet you don't think about, right? Like, it's just like the sort of, approach to thinking more about your health and your hunger and your body and, what you're craving and what your family enjoys and what's in season, far more than like a very prescriptive, I'm thinking this is like the time South Beach diet was getting really popular, and Atkins diet was still on everyone's agenda, and they just wanted this like prescriptive diet, when it's like that will cause you more anxiety and stress and worry, and probably ultimately cost you more money and feel less accessible than some of these intuitive eating principles and tools. And it's tough sometimes. I think as dietitians we shouldn't have the jobs we do, because it is ultimately telling people to like look at what you eat, think about how you're feeling, practice the foods that you enjoy, and, see sort of how ultimately that results in your goals. So at times when, I feel like it's silly that we tell people how to eat, but we're doing a lot more walking alongside people when it comes to using these tools, Health at Every Size and intuitive eating, and meeting so many more people, different populations, different conditions, where they're at. So one of my last questions is how really do these types of interventions and tools shift away from traditional approaches that have been used in nutrition counseling, and where have we come from, and maybe where is nutrition counseling and education going?
So I think it's really, really patient-centered, which, people talk about patient-centered care, and I think sometimes we don't really embrace it to like its deepest level. Because I mean, it's easy to be like, hey, do you want this medication? Yes or no? And then it's like, oh, they didn't want it, so we're going to try something else. And yes, like on some level, that's patient-centered, but you really have to know the patient. You have to know what they struggle with, and then also what they want to change. So sometimes a patient, you'll think as like an expert that you need to change a specific thing, or they really need to stop drinking soda. But maybe to them, that's not what they want to work on. They want to work on, adding more movement or having healthier snacks. And so then you need to kind of be able to focus on what they want to focus on and look at what they're excited about. So yeah, I really think that is a big thing moving forward. I think a big thing is just really it being very integrative, because it is like mental, it's emotional. You need to know the science, and then you need to be able to be practical about things, because you can know the science and be like, this is the best diet ever, but are patients going to want to do that? Does that work for that patient? So it's a lot of like finesse and really allowing everyone to be their own person, but helping them achieve their own goals.
Yeah, excellent. I think I'm more optimistic about the direction nutrition counseling is going than ever before. Catherine, is there anything else you'd like to share about your practice, about food access, health equity, some of these topics that we've touched on?
Yes. So I was thinking, so all of this kind of ties together in some ways. So there's interesting stuff about how weight bias actually messes with intuitive eating. Because we're so worried about losing weight, we stop focusing on how we feel when we eat certain foods. So that adds to it. And what's interesting is the cultures that are the healthiest don't really they don't have a prescriptive diet. They eat their cultural diet, kind of like what you're saying about they don't think about it. Like, they don't stress about their food. They're not like, oh, is this birthday party too many calories? Like, they literally just go to their birthday party. They play with their friends. They do their normal lives, and they're healthy, and they're a good weight. And, they're really able to maintain that health. And one of the things some people speculate is that part of the reasons we have so much obesity is because we focus so much on being thin that it creates disordered eating, which then creates obesity. So if we can move away from that and just be more accepting and caring towards everyone, then we could all be healthier, and we could possibly fix the obesity problem without even talking about weight loss.
About weight loss. This also sounds like it goes beyond the profession of dietetics.
It does. I mean, it's very, very interdisciplinary.
Yeah, so all of our healthcare team, should be learning a little bit more about the ways that we can approach food and nutrition and lifestyle.
Yep.
Do you have a lot of interprofessional work experience? Do you do some team care for any of your patients, or, is there changes in our healthcare system around the conversations of improving patient outcomes through nutrition? Yeah,
so team care is much harder in the outpatient setting than I feel like it should be. When I worked at a nursing home, it was very integrative, and I loved it. We actually had integrative meetings about a patient with all the different medical staff, and we would talk about how this patient was doing. All of my patients, almost all of my patients, have therapists. That's something that is kind of required if they are struggling with emotional things or body image things. They really need to have a therapist. So they definitely have that. And I would say we don't really, communicate very much, but we definitely work off of each other and talking with the patient. And, sometimes certain things it's okay, you should discuss this with your therapist, different things like that. So I would definitely say that. You definitely need doctors involved for labs, medications, other stuff. I definitely think it could be more interdisciplinary. And I think when you work at a clinic, an outpatient clinic where everyone else is outpatient, works really well. I kind of like the idea of having more holistic, instead of it being a doctor's office where it's we're gastroenterology, I want just we're an office and we have a therapist and a doctor and a dietitian and a physical therapist, and everyone just communicates and cares for patients, because that's really what you need to have good patient outcomes.
That's a great vision for healthcare model of the future. And I love what we do at UB in at least preparing our dietitian students to understand the role that each of those other health professions play, and then to those health professions, the role of the dietitian, hoping that eventually they'll, hinge off each other for patient care, but having us all under the same roof would be a benefit to the patient for sure.
Yeah.
I've heard this term food sovereignty out there, but I don't know much about it. What can you tell us?
Yeah. So it actually loops back into a lot of the food access things. And so food sovereignty is having control over your own food, like where you acquire food, make food, grow food. So a good example is like where I live, I'm not allowed to have chickens. And so that's kind of a barrier between me being able to produce my own food. And it used to be that people could produce their own foods however they wanted. They could forage, they could hunt. And now we have more and more laws saying like, well, you can only hunt these times of year. You can't forage in this area, different stuff like that. And so if we allow people to have more control over how they acquire food, they then can have less food insecurity. And there's really interesting stuff happening with that. Like in Maine, they made a law that you cannot have any zoning limitations. So like if you want to plant a vegetable garden in your front yard in Maine, you can do that now. If you want to have goats for goat milk, you can do that. There's none of these barriers. A really common one too is even with like food processing and sanitation, which is important, but at the same time, they'll create such high costs to like properly process the foods that then small farmers or individuals aren't able to do the things that they need to do to make their own food. So the idea is just having food access being more diverse. So you're not just going to a grocery store, but like what are other ways we can get food and like nourish ourselves and have control of our food environment?
I know there's some environmental challenges, but I see folks who are from, refugees from other countries fishing in the Niagara River all the time. And I'm thinking, they're used to their waterways, being a food access point. We have different challenges here environmentally with using that as food access. And so we've had to put these limitations on, fishing in our waterways essentially, because we know there might be some health concerns from the fish coming out of there. But that these folks are so used to using that as a food source, and we have to tell them, no, we don't recommend it, you can't do it. There's laws against it or recommending against it. So it's interesting that food sovereignty also might play into, the environmental conditions in our neighborhoods and in our, built environment here.
So I have an interesting story is I went to the Cayman Islands. Have you ever been there? Mm-hmm. So they have just fruit trees growing everywhere. Like you just buy a house and it comes with a mango tree or like a coconut tree because it's tropical. And then they had a hurricane like 15 years ago and all the chicken coops broke. And so now there are just wild chickens on the island. So if you put like a roosting box, like they'll just lay eggs in your backyard and then you just have free eggs. So like everyone on the island is just like, yeah, I just get free eggs from my backyard. So it's just a really cool, like different way to think about food and how to acquire food.
Yeah. I feel like there'd be another conversation about, the role of hunting and even our deer population and, the ethics around food procurement of hunting and, how mixed people feel about that sometimes.
Yeah.
For another day. All right, this has been another episode of Buffalo HealthCast. Thank you to our guest, Catherine Brown, for taking time to speak with us today. Nicole Klem is our faculty consultant. Sarah Robinson is our production assistant. Omar Brown is our sound editor. And our theme music was written and recorded by Sungmin Shin of the UB Music Department. My name is Nicole, your host and writer for this week's episode. Thank you for listening, and tune in next time to learn more about health equity in Buffalo, the U.S., and around the globe. Thank you.